from the UK. Dr. Manal, please, we look forward for you to deliver your speech.
Good morning. So can you see my screen or not yet?
Yes, we do see your screen and we can hear you clear.
Thank you. Good morning. Thank you, first of all, for giving me this chance to share this rather exciting development that we have come across during what has been a year of doom and gloom during the pandemic.
I received a missed call from your number. That is why.
Firstly, I would like to thank my team, Dr. Futan Dipe and Mark Chapman, for their hard work. Sorry, can you hear me?
Yes, we can hear you very well. Just a note for the other participants: please be sure that your microphones are muted to prevent any communication problems. Thank you. Well, Dr. Manal, please continue.
Thank you so much. So I share with you the plan for this talk. I'll give you a minute to have a look at it. And when you're ready, brace yourselves and let's hit the ground running. So we know that COVID-19 has become a worldwide pandemic, sadly, since the beginning of 2020, and it is still carrying on till 2021. So far, 95 million confirmed cases infected by COVID-19 internationally, out of which 2 million sadly have succumbed to the coronavirus infection. We also know that despite the tremendous effort and the rapid development in the symptomatic control in patients with COVID-19, we're still to see a really effective treatment for this beast. And we cannot undermine the global effort for the vaccines that has come together internationally to approve vaccines for COVID-19 in such a short period of time, which have been rolled nationally, thankfully, and internationally. However, with the emergence of new variants of the coronavirus, there are question marks about the coverage of these vaccines and the new variants. And the question that us as a team would like to ask is whether there are any viable alternatives for treatment for COVID-19. A bit about the COVID-19 epidemiology. I'm pretty sure we're all sick with it so far, hearing the COVID-19. But we know that COVID-19 infects a broad spectrum of the population. And through the research during the pandemic period, we are aware now that we have identified an at-risk group for COVID-19 infection. There is a long list, amongst which I would like to highlight men being at increased risk, those from minor ethnic back groups being Black, Asians, and the other minor ethnic back groups, those who are obese, with diabetes and cardiovascular disease. So that is just to highlight the most important at high-risk groups, although there is a long, extensive list present at the WHO websites. But what we also know as well is that the majority of people, once they are infected with COVID-19, they are either asymptomatic or they develop mild symptoms, but yet they are still infective. 15% of those infected develop severe disease, and a further 5% become critically ill with the coronavirus, and the majority of those succumb to the disease, although we have seen few success stories of recovery from being on an ICU bed due to COVID. And the presenting symptoms of COVID are quite a wide range of manifestations. And this, in fact, reflects that the coronavirus actually infects multiple organ systems, the most common being the respiratory system. But there are other systems involved, such as cardiovascular, such as the GI system, liver, kidney, and even skin manifestations are emerging. And nowadays, there is a new kid on the block called oxytocin. So what do we know about the relationship of oxytocin and COVID-19? We know that research has proven so far that in the cohort which is labeled as high risk group for developing COVID-19 infection, those individuals have a low oxytocin plasma level when compared to the general population, which are healthy and do not have the high risk factors for developing the coronavirus. Furthermore, we know that once infected by COVID-19, the function of oxytocin is reduced, and the research so far has proven two pathways for such a hypothesis. The first being that there is a downregulation of the oxytocin receptors once the human body is infected by COVID-19. And the second being that oxytocin is normally produced by the hypothalamus, and the theory is that the virus infects the neurons within the hypothalamus and therefore leads to reduced production of oxytocin, the so-called viral cytopathic effects within the neurons in the hypothalamus. And there are radiology papers highlighting the effect of COVID-19 on the hypothalamus during COVID-19 infection. But is oxytocin really a new kid on the block, or have we known about oxytocin before? So oxytocin was discovered in the early 1900s by Henry Dale. So it is not a new kid on the block. It is a peptide hormone and a neuropeptide. And as I have mentioned, oxytocin tends to be produced by the hypothalamus, and it is released by the posterior pituitary gland. It was initially thought in the early 1900s, when it was discovered, that its role is in social bonding, in reproduction, and in childbirth. And once it gets released into the bloodstream, it is usually triggered by love and labor. So that is the knowledge that we have acquired in the early 1900s. But why would an oxytocin, which has been labeled historically as a love hormone, play a role in the COVID-19 infection? And is that possible at all? We now know through the emerging published research that oxytocin has an anti-inflammatory and a pro-immune function against the COVID-19 infection. And I share a very recent paper highlighting this. So we know now, contrary to the beliefs in the early 1900s, that oxytocin receptors are found throughout the body. We also know that it has a wide range of effects. So that's new knowledge, new evidence acquired through the research during the period of the coronavirus pandemic. So oxytocin has an immune modulator function. It also works as an immunological defense. It maintains homeostasis, and it suppresses neutrophilic infiltration and inflammatory cytokine release, as well as modulating T lymphocytes and antagonizing negative effects on angiotensin II. And I would really as we tried to take the GI system as a microcosm in the body and see those who have developed severe COVID-19 GI symptoms and ask the questions, could we explain those severe COVID-related GI symptoms by the oxytocin dysfunction? So nowadays, we know through the research that the GI tract is a potential route of COVID-19 infection. And let me stop here and say that as a GI pathologist, during the pandemic, all our protocols have changed due to this fact. Nowadays, all of our colorectal resections, whether cancer or non-cancer related, are left in formalin at least for 48 hours even before opening, purely because of the impact of this finding. We know that there is a significant proportion of the initial and even long-term symptoms of the COVID-19 infection are accompanied by GI symptoms. Luckily, I didn't have, I was lucky not to catch coronavirus, but those who have been unlucky will tell you about the diarrhea, the nausea, the vomiting that they have experienced purely due to the coronavirus infection. And now we know that oxytocin receptors are found throughout the GI tract. Mainly, they are found within the surface epithelium and again in neurons, similar to what originally was thought to be only the hypothalamus. And nowadays we're talking about oxytocin dysfunction and its effects on the GI tract. So we know that due to oxytocin dysfunction, there is an increased stool mass, increased water content, and increased transit time, as well as increase in the permeability of the intestinal wall to macromolecules, all of which presenting in COVID-positive patients as the diarrhea. We also know that the lack of adequate levels of oxytocin lead to decreased GI mucosal cell proliferation, decreased villus height and crypt length ratio. And I'll stop here and just alert reporting pathologists that nowadays when we're receiving GI biopsies, especially from the small intestine duodenum, query celiac disease, which is not an infrequent occurrence on a GI pathologist's desk, bear in mind that COVID-19 leads to decrease in the villus height and crypt length ratio. So entertain this in your differential diagnosis and check the past medical history. And the last but not least, low levels of oxytocin lead to decreased protection against inflammation and hence all of the manifestations, GI manifestations of the COVID-19. And there is a decrease in mucosal defense against toxins, hence the vomiting, the nausea, and again, the diarrhea. So how can we reflect this in reality? I'm just going to share with you a case that came across my desk yesterday for a second opinion. These are GI biopsies that I'm going to share from a 64-year-old female. Of significance is the presence of a past medical history of COVID-19 in December 2020, and the patient now presenting with acute diarrhea, so nearly not quite 6 weeks history of diarrhea, and a positive fecal occult blood test. She underwent a colonoscopy, and she has colonoscopy was normal, no findings. So random biopsies as per protocol were obtained. The process of thinking being, let's exclude and let's see if there is any drug effect, and the list goes on and on. So low power review shows, I'm just going to share one biopsy with you because the morphological features are similar in all of the biopsies. This is a right-sided large intestinal mucosal biopsy, which shows that there is a preserved crypt architecture. Just bear in mind that this is a right-sided biopsy, so chronic inflammation and the gradient, you're allowed a bit more leeway on the right side. But still, despite all of that, the lamina propria looks quite busy. So let's see what's happening. So crypt architecture quite maintained, and what we're seeing is there are polymorph neutrophils within crypts, not yet crypt abscess formation, and there is quite abundant polymorph neutrophils within the lamina propria. So a picture of acute colitis, for which the differential diagnosis top of the list is infectious colitis. And the question to be asked in this situation is this really an acute colitis occurring secondary to the COVID-19 infection? I would like to tell you that the stool cultures were negative, but they haven't yet been tested for COVID-19. So that's something still remaining to be confirmed in this case. But the take-home message from this case is, A, look at the past medical history, ask your clinicians to supply a past medical history because it can be quite relevant in situations like this. So what are we hypothesizing and where are we going with this? It's a lot of science, but what do we want to do with it? So far, we know that oxytocin dysfunction contributes to the GI symptoms that are produced in the COVID-19 infection. And what we are hoping to achieve is, if we have normal plasma oxytocin levels, to protect against these GI symptoms that are produced during a COVID-19 infection. The good news are that oxytocin is available, it is cheap, and it is safe. And once administered, it can alleviate the GI symptoms produced during the COVID-19 infections. This oxytocin is available on the market. It could be through intranasal spray, it could be through intravenous infusion. And what I would like to share with you is a recent paper that has been published where they have used an intravenous oxytocin infusion to try and counteract all of the hyperinflammation that's seen in a COVID-19 infection. And what we are hoping to achieve is by getting the approval to administer oxytocin, with that being exogenous, as we have explained, through intranasal sprays, through intravenous injections, through capsules, that we will be able to raise the serum levels for oxytocin and therefore act as hopefully a prophylactic protective mechanism against developing GI symptoms. For now, we're talking about COVID-19, but who knows at the end of the path what we will be able to protect against. And so far, the what we have found is that COVID-19 is being recognized to exert its effect through a multi-organ involvement. That ties in nicely with the presence of oxytocin receptors throughout the body and its healing and protective effects in the COVID-19 pandemic. I also like to share with you a hot off the press paper that has been published about the cardiovascular protective properties of oxytocin against COVID-19 infection. So we are here moving towards prophylaxis and prevention of even cardiovascular disease. I mentioned that oxytocin can be administered exogenously. However, why bother when it is present endogenously within the body through exercising, meditation, listening to your favorite music, massages, touch? All of this facilitates the release of oxytocin and therefore increases the plasma oxytocin serum levels and acts as a protective mechanism. So get on your running boots and get those oxytocin levels up. Our recommendations is to get an approval for a randomized controlled trials in COVID-19 patients to prove the effects of the administration of oxytocin. We would like to map the oxytocin receptors presence along the colorectal cancer pathway and see, hopefully, if in the future we can integrate oxytocin treatment within the personalized medicine cancer treatments that are being delivered. And I would like to share that a few days ago, a paper has been published about using oxytocin in the treatment of cancers, and different types of cancers have been, patients that are terminally ill have received oxytocin and their survival levels have improved. So I think that's the light at the end of the tunnel. And before I finish, I would like to ask anyone who's interested in such a research or would like to take part in such an exciting development to please contact me and contact my team, and let's get those efforts internationally to spread the word. Thank you, and I'd like to take your questions.
Yes, thank you, Dr. Manal, for this.
Sorry, you're muted.
Okay. Well, thank you. Thank you, Dr. Manal, for this very actual and comprehensive presentation. We do not get tired hearing about COVID-19 because it will become to our usual clinical routine. And the more we know and the more we can do, the better it is. So are there any questions from the audience? So I got